Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. Yesterday we studied about the intestinal obstruction, the general features. Now, today let us study about intestinal obstruction to specific diseases. We have seen various diseases causing intestinal obstruction. So let us group them all into mainly age-wise. In the neonates, in the infants and children, in the adults, and in the elderly people. So like that we will classify them and let us see the various causes and how they manifest in each group. So intestinal obstruction in the newborn, in the children, in adults, and in elderly. So first let us study about acute intestinal obstruction in the newborn. Causes: congenital causes like congenital atresia and stenosis, valvulus neonatorum, meconium ileus, Hirschsprung's disease. This Hirschsprung's disease may manifest either in the neonatal period or few weeks after birth or sometimes even in the adult age. That depends upon the number of aganglionic cells that are present in the rectum. We have discussed about that. That is why we will skip this Hirschsprung's disease here. Congenital atresia or stenosis. Atresia means non-development. A part of the bowel do not develop. So when the part of the bowel do not develop, what will happen? In its place, you will find a fibrous structure, a fibrous band. So these sites where it can occur are the duodenum, that is common site, jejunum, ileum, ascending colon, or sometimes multiple sites. There may be associated cardiovascular anomalies. So any congenital disease can have associated cardiovascular and sometimes even other parts of the body anomalies. Etiology: intrauterine localized bowel ischemia, which later is absorbed and replaced by scar tissue. So about 1 centimeter or 2 centimeters or 3 centimeters length of bowel is replaced by thick scar tissue. That is atresia or stenosis. Atresia of the duodenum. Already we studied about this. That's why we are not going to discuss this here. Just I will ask one question here about atresia of the duodenum. What is the site of the atresia of duodenum? What is the site where you find duodenal atresia? What is site? Only 2 students have answered. Okay. Yes, Santi, you are right. What you said first is correct. That is the junction of the foregut with the midgut. So that is the commonest site. That means that corresponds to the papilla of Vater. So that is the site of the duodenal atresia. Can you tell me the X-ray finding, X-ray abdomen finding in atresia of duodenum? Okay. What I find is usually only some 3 or 4 or at the most 5 students are making the answers or participating in the interactive discussion. I suggest all of you to participate. Then only a teacher on interactive online classes will be able to see you. Now I can't see you at all, but through your answers, I will be able to see you and I will be able to gauge you. So please reply, all of you. Though you know it pretty well, but sometimes I will be just asking questions to know whether you are attentive or not. So please reply. Yes, you are right. It is the double bubble sign. Ectasia of the jejunum and ileum. So you can see here, this part of the jejunum is not developed. It is now a fibrous structure. So we have seen in the intestinal obstruction, proximal to the obstruction, there will be dilatation. Distal to the obstruction, there is collapse. So the distal part of the bowel is collapsed, including the colon. The jejunum is grossly distended. So whenever such gross distension is there, that can lead to even atonia. Sometimes there can be even gangrene. Already I told you, whenever the bowel is stretched beyond a critical point, there is a chance of undergoing gangrene. So clinical manifestations, abdominal distension early or within 24 hours after birth. Bilious vomiting. How do you differentiate this condition from duodenal atresia? Duodenal atresia also manifests with the bilious vomiting from the birth itself. So how are you going to differentiate bilious vomiting from duodenal atresia? Yesterday we have seen the abdominal distension is directly proportional to the distal extremity of the obstruction. That means more distal the obstruction, greater the abdominal distension. In jejunal atresia, there will be gross abdominal distension. In duodenal atresia, there is minimal or no abdominal distension. Usually, the patients will be getting the bilious vomitings without much abdominal distension. Investigation, plain X-ray of the abdomen. Tell me, by looking at this X-ray, what are the findings? And tell me also, is it a supine view X-ray or erect view X-ray? X-ray can be taken in the erect posture or in supine posture. Is this X-ray taken in supine or erect? Number 2, what is your finding in this X-ray? First tell me, is it supine X-ray or erect X-ray? If you are not able to tell, just mention you can't. So because there is no answer, I just simply say that I hope you are unable to say that. Okay. Now you can see this is glass of water. When you are shooting this from front and keeping it erect, you are seeing this is air, this is air, this is water. Between these two surfaces, there is a straight border. Okay? But now, if I keep like this, that means in supine position, and take an X-ray, then what happens? You won't get this horizontal border. The water will flow. The air will be there in some lockless. That is why you will get some crescentic shadow. Whenever you see a horizontal fluid level or horizontal level lower border for a air shadow, that means that the X-ray is taken in erect posture. You can see all these air shadows. They have horizontal borders. So that means it is a erect posture X-ray. That's number one. Number two, the finding. What finding you are seeing here? You are seeing multiple air bubbles. Are the bubbles? No. If they are round, we call it as bubble. But it is round only in the top. At the bottom, it has a horizontal border. This has a horizontal border. This is horizontal border. So like that, you are seeing multiple air fluid levels. So whenever multiple air fluid levels are there, distributed throughout the abdomen, that means that you can count here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, some more than 15 air fluid levels are present. That means it is a ileal obstruction. Number two, it is an advanced obstruction for more than 48 hours. When you open, you can see the bubbles are like this. So there are collapse, and proximal part of the bubbles are grossly distended like this. This is jejunal atresia. Management. So whenever atresia is there, you must remove that segment. Otherwise, there is no use in having that atresia segment. And you remove that segment and do the end-to-end anastomosis, that is okay. But what happens here? The proximal part of the bubble is grossly distended. Distal part is very narrow. So it is just like a rat tail. This is like an elephant trunk. So you have to do the anastomosis between these two. So technically, it poses some problems. So what you do is, in case of ileal atresia, you can do Paul Mikulicz procedure. Already I described Paul Mikulicz procedure in the previous class. You make the two loops as double barrel. Then you keep them outside. 48 hours later, you cut this. It becomes ileostomy. The distal part also is cut. Into these two loops, you introduce enterotome. A long bladed instrument will be there that is passed and is gradually tightened. The screw is tightened. The blades gets approximated and they get tightened, and the septum in between, it gets crushed and necrose, and it separates. Once it separates, the clamp what you have applied there, that enterotome falls off on its own because it has no support there. So once it falls means the septum has been lost. So the contents will go from this end to this end. Once the child condition improves, then what you do is you close these openings. You close these openings, just push them inside and close the overlying skin. So this is called the Paul Mikulicz anastomosis. So for the ileal atresia, this is a very simple operation that you can do. For jejunal atresia, if you do Paul Mikulicz anastomosis, through the jejunostomy opening, there will be loss of lot of fluids, electrolytes, enzymes, causing lot of skin excoriation. That's why the child cannot thrive. So what you do is you do end-to-end anastomosis by this method. That means you can see the distal segment. The distal segment opening is only this much. That's why what you do is you cut this border also. You cut the antimesenteric border so that its opening becomes almost equal to that of the proximal part, and you do the anastomosis. You can do see here. This is the proximal dilated segment. This is the distal segment collapse. So the proximal segment, it is cut here. This is the opening. This is the distal segment. It is made a longitudinal cut on the antimesenteric border. Now you take a bite to the apex of this cut end. This is also called fish mouth anastomosis. This is called fish mouth anastomosis. So you take a bite of another suture from the lower side. So when you do the anastomosis, this will come like this. So this is almost an end to end and side anastomosis, to the end as well as side. So end to end side anastomosis. So that is about the ectasia of the jejunum or ileum. The next condition is the volvulus neonatorum. Volvulus means twisting. Volvulus neonatorum means it is volvulus of the midgut due to defective rotation of the gut during development. What is the extent of midgut? Where from it starts and where it ends. What is the extent of midgut? Okay. Very good. Sorry, I have not seen the chat box because there was some problem in the chart scrolling. So, though you mentioned erect X-ray and all that, I could not see that. That was hidden. Now I can see this. Oh, sorry, I said that you were unable to say, but all of you have said correctly as erect X-ray, and you have mentioned air fluid levels. So I appreciate. Yes, midgut means it is from papilla of water level in the duodenum, that is middle of the second part of the duodenum, to junction of right 2/3 to the left 1/3 of transverse colon. This whole thing is the midgut. So this whole midgut undergoes twisting like this. How can it undergo twisting like this? This can happen only when there is a maldevelopment in the gut. That means development is normal, but there is some defect in the rotation of the gut. So what is all this rotation of the gut? That is why just I will take few minutes to explain you the rotation of the gut. Then you will understand how a malrotated gut can predispose to volvulus neonatorum. Yes, I will explain. I will just show you some of the images, how the gut undergoes rotation. This is the embryonal disc. This differentiates into foregut, midgut, and hindgut. The foregut actually communicates with the yolk sac in the early weeks. Later, the foregut develops in the yolk sac. You can see this is the foregut, this is the midgut, this is the hindgut. This is the umbilicus. That means in the first week or first few weeks of life, the whole midgut is in the umbilical cord. This is all in the umbilical cord. Then what happens? Once it gets developed, by the end of 5th week or 6th week, this whole gut will go inside. How it goes inside? There is a method. It goes in a methodical way. Once it goes inside, then it develops again. So this is called the rotation of the gut. So in the development, there is development of primitive gut into foregut, midgut, and hindgut. This is the primitive gut. This differentiates into foregut, midgut, and hindgut. There is physiological herniation of the midgut in the umbilical cord. This is the umbilical opening. This whole thing is the umbilical cord. So in the umbilical cord, the midgut loop lies. It rotates for returning into the abdomen. Once it goes into the abdominal cavity, it gets fixed there. So these are the 4 steps in the rotation, in the development of the gut. You can see this is the embryo of 5th week of intrauterine life. This is the developing gut, just like a tube. There is some dilatation here that represents the foregut, the stomach. Then this is the midgut, and this is the hindgut, and this is the vitellointestinal duct. That means midgut has a duct. This is the vitellointestinal duct. This goes into the yolk sac. All this is the umbilical cord. Here is the umbilical opening. Here is the umbilical opening. Now, after development of this foregut, then there is no space inside the abdominal cavity. So the cavity has not developed by 5th week of intrauterine life. That is why there will be herniation of this midgut into the umbilical cord. You can see this is the midgut. It has herniated here. And this is the vitellointestinal duct from the apex. This is the umbilical vein. There are the umbilical arteries. So this whole thing is the umbilicus. The midgut stays in the extra embryonic coelom, that means in the umbilical cord, during early embryonic life. Persistence of this abnormality, sometimes the child will be born with the same abnormality. The midgut won't return to the abdominal cavity. It will retain in the umbilicus itself. Then we call that condition as omphalocele. So this child is born with all the guts in the umbilical cord. Just like a thin sac is there. In the sac, the bowels are there. Over the sac, the umbilical vein, umbilical arteries, Wharton's jelly are stretched. After delivery, once you sever the small stump of umbilicus from the placenta, then this sac will be there with containing bowels. This is called exomphalus. Of course, we will discuss about this when we talk about the hernia topic. Also called as omphalocele. There is a similar condition called gastroschisis. Gastroschisis is a condition where the bowel develops inside the abdominal cavity, just like a normal child. But during the birth of the child, there will be a small tear by the side of the umbilicus in the abdominal wall. Through the tear, the bowels will come out and they will be on the abdominal wall. So, in the gastroschisis, there is a normal spaced abdominal cavity, but bowels have herniated out through a opening in the abdominal wall. That is gastroschisis. Example is all the midgut loop develop outside the abdomen. They didn't go into the abdominal cavity during development of the child. So they were in a thin sac, that is amniotic sac, covered by Wharton's jelly. Now, when the child is born, sometimes the sac may be intact, sometimes the sac is burst, making the bowels on the abdominal wall. So in both these conditions, gastroschisis and exomphalus, bowels will be on the abdominal wall. In first condition, gastroschisis, the bowels are developed inside the abdominal cavity in a normal abdominal space. Why I am telling this space means it is easy to operate gastroschisis because already the space is there. So what you do, just enlarge the opening, put all the bowels again inside, and suture the rent. That is sufficient. But exomphalus major, there is no space. You need some special technique to create space in the abdominal cavity. Then only you will be able to repair the exomphalus. By inspection also, you can say whether it is exomphalus or not. Exomphalus will have a sac. Gastroschisis has no sac. Exomphalus has a very thin abdomen. Gastroschisis has a normal abdomen. The shape of the abdomen is normal. Okay, let's come back to development. So the midgut loop develops in the umbilical cord. This is the umbilical opening. Now, this is the future duodenum. This is the stomach. This comes here. This is the duodenum. Here is the second part of the duodenum. So at the second part of the duodenum or at the papilla of water level, the midgut has come outside. And here is the dilated part that is called the cecum. And this is all the colon. So this for the midgut loop, the base is by the duodenum and transverse colon. Then you put together, this is called as the duodenocolic isthmus. This is called the duodenocolic isthmus. Now it goes inside the abdominal cavity by a mechanism called rotation. There is 3 stages. First stage during 5th to 10th week. Second stage 10th to 11th week. Third stage 11th week to before birth. So for a very long period, the third stage will be there. First stage of rotation. You can see here. This is the foregut loop. Here is the foregut loop. This is the junction of the foregut with the midgut. So it's coming like this. And now it goes and becomes the hindgut. And there's superior mesenteric artery coming and ending here at the apex. So this is the loop. This is the apex of the loop. And of course, from the tip, there will be vital intestinal duct. Now, at the 5th week of intrauterine life, liver starts developing. It is enlarging in size. This is in the umbilicus. Midgut is in the umbilicus. Umbilical vein is there. We have seen umbilical vein goes and joins the portal vein. So this umbilical vein goes and joins with the portal vein. As the liver is developing, then what happens is it drags the umbilical vein to the right. The umbilical vein is dragged to the right. So because of its dragging, what happens is this particular loop, this loop is called the pre-arterial loop because this is superior mesenteric artery. That part of the midgut loop, proximal to that one, is called the pre-arterial loop. That part of the midgut loop, distal to the artery, is called the post-arterial loop. So this pre-arterial loop, because of the drag of the umbilical vein, it twists. The loop is so this is the midgut loop. Once the umbilical vein comes and pushes to the right, this loop, which is like this, it turns like this. Originally it is like this. Because of the development of the liver, the umbilical vein is pushed to the right or dragged to the right. So that umbilical vein goes in the middle of the loop. So that is why it is like this. So because it's dragged, it turns to the in this rotation. So this is the first stage of rotation. So now the pre-arterial loop, which is at 12 o'clock, is now turned to 9 o'clock. The post-arterial loop, which is at 6 o'clock, is now turned to the 3 o'clock position. So this is the first stage of rotation. Development of liver causes displacement of umbilical vein in the umbilicus. This displaces the pre-arterial loop down and to the right. Then the second stage follows. What is the second stage? Now, as the fetus is growing in size, there will be developing some space in the abdominal cavity. So the abdominal cavity is also expanding. So with that expansion, the bowels now will try to retrieve into the abdominal cavity. They want to go inside the abdominal cavity. As a bulk, it can't reduce because the umbilical opening is narrow. Whole part of the midgut can't go inside the abdominal cavity. So that's why what they do, they follow a pattern. So what is this pattern? First, the pre-arterial loop passes inside. So this pre-arterial loop first reduces inside. So this pre-arterial loop is gradually going inside. Almost most of the pre-arterial loop has passed inside. So the pre-arterial loop has passed almost. Just one little bit of pre-arterial loop is there outside. Now, once the pre-arterial loop goes inside, the post-arterial loop also follows that. So it also goes inside. So ultimately, you can see the whole pre-arterial loop and post-arterial loop has passed inside. Now, you can see here in the second image, the pre-arterial loop is passing behind the superior mesenteric artery. You can see here, it is going behind the superior mesenteric artery. So this part is the duodenum. So that is why the third part of the duodenum lies behind the superior mesenteric artery. It lies behind the superior mesenteric artery. If you just recall our pancreas anatomy and the images I have shown you there, you'll see the superior mesenteric artery running across the third part of the duodenum. That is because the pre-arterial loop of the midgut loop first goes inside the abdominal cavity and that passes behind the superior mesenteric artery. So the duodenum lies in front. And the post-arterial loop returns to the last. The transverse colon comes to the last. That's why by that time the superior mesenteric artery has been reduced inside. Then the post-arterial segment goes inside. So that is why the transverse colon, which is developed from the post-arterial segment, lies in front of the superior mesenteric artery. So this is the second stage of rotation. This is one of the most important stages. I hope you understood this stage, this method of this rotation. Is it clear? Or shall we need some more explanation? Okay. The midgut loop returns to the abdomen in a definite manner. Proximal portion of the pre-arterial segment returns first. The gut returns to the right of the artery and enters the abdominal cavity behind the vessel. Now by this time, the peritoneum has not developed. That is why there is no question of peritoneum and retroperitoneal structures here. Later, the peritoneum is developed. After the rotation has completed, that means after returning of the bowel inside the peritoneal cavity, then the peritoneal membrane starts developing. The entering loops of the midgut pushes the hindgut mesentery and hindgut to the left. The last coil of the ileum is reduced with the artery. Later, the cecum and ascending colon reduces. This makes the cecum and ascending and transverse colon to lie anterior to the artery. You can see here, the red line is the artery. This is the colon. It lies anterior. So after reduction during second stage, this is the picture. The cecum and ascending colon and transverse colon has not yet differentiated. They all lie as a single tube and that lie across the abdomen horizontally. So at the end of the second stage, the cecum is just below the liver. Umbilicus is here and cecum is here. So this is the normal pattern of rotation. Duodenum crosses behind the superior mesenteric artery. Transverse colon lies in front of the vessel. Descending colon is pushed to the left. Duodenocolic isthmus, which was narrow when it is like a loop, now it becomes wide. Third stage, the colon develops. As the colon is developing, because it's lying horizontally, there is no space. So it just turns around and then comes downwards. So cecum descends downwards. Ascending colon and descending colon are fixed to the posterior parietal wall. So now the peritoneum develops at the end of the third stage. Peritoneum is well developed. So the ascending and descending colons, now they became retroperitoneal. Sometimes there can be some errors in the rotation. Errors in first stage occurs very rarely. That's called extraversion of the cloaca. Errors during second stage, that means reduction into the abdominal cavity in an orderly fashion. Number one, non-rotation. This is also called arrested rotation, reversed rotation, malrotation. These are the three errors that can occur. Errors in third stage, subhepatic cecum. Cecum fails to descend downwards. It lies under the liver in the right hypochondric region. Mobile ascending colon. Ascending colon and descending colon, they fail to get fixed to the posterior abdominal wall. They remain mobile. They have a mesentery, just like transverse colon. What is arrested or non-rotation? This is the midgut loop at the end of 5th week of intrauterine life, situated in the umbilical cord. What I said was, because the umbilical opening is narrow, whole of the midgut loop can't go inside at a time. That's why it gradually goes inside. So the first the prearterial segment goes inside, later the postarterial segment follows it in an order. For example, if the umbilical opening is very wide, then what happens? There is a cavity developing inside the abdomen. So all this loop of the bowel just goes inside like that without passing inside in an orderly fashion. So now you can see here, this loop is situated outside the abdominal wall. If it goes inside just like that, it will be the picture. Inside the abdominal wall cavity also, it will be like this. Can you understand this picture? This is stomach, this is duodenum, this is this third part of the duodenum. Instead of duodenum going like this, now it came straight like this. This is all the ileum, small bowel, that means jejunum and ileum. And from here, this is cecum. This is the ascending colon, and here is the transverse colon. And this is the descending colon. So this type of arrangement will be there in the abdominal cavity. This is called arrested or non-rotation. So whenever umbilical opening is very large, the whole midgut loop just reduce inside without following an orderly retreat. So this will be like this in the adult. This is the most common anomaly. You can see the small bowel on one side, a large bowel on the other side, with superior mesenteric artery in the middle, and the duodenum and transverse colon are quite near to one another. So then what do we call this now? Now this is a loop, and this is the base of the loop. So this base of the loop is called the duodenocolic isthmus. The duodenocolic isthmus is quite narrow here. It's not wide, it is narrow. So the second stage of rotation is absent, loop reduces inside as such. And the cecum occupies the left side of the abdomen. So the cecum is now on the left side, not on the right side of the abdomen. Usually in the left hypochondrium to the left of the artery. In these cases, there will be an associated band passing from the cecum to the abdominal wall across the second part of the duodenum. This is called transduodenal band of Ladd. This is one of the frequently asked questions in the theory examination, short notes. Transduodenal band of Ladd. This is nothing but a band which stretches from the cecum to the anterabdominal wall across the duodenum. This is present in all the cases of non-rotation of the gut. And this band, because going to the anterabdominal across the duodenum, it causes obstruction to the duodenum. You can see here, the duodenum is obstructed here. Just like duodenal atresia, the duodenum is dilated here. So clinical features and X-ray are similar to duodenal atresia in this case. Of course, the treatment for this problem is you just cut the band that will relieve the obstruction. Reverse rotation. We have seen the prearterial segment normally reduces first, but sometimes what happens, the postarterial segment reduces first. Then what happens is transverse colon lies behind the artery. This has no significance. This won't cause any problem to the patient. This is only for our observation. That means when you do surgery for a patient with gastrojejunostomy, for example, then you will find the transverse colon going behind the superior mesenteric artery and duodenum crossing in front of the superior mesenteric artery. Then you will be perplexed to see that particular arrangement there. What are the effects? No functional disturbance. Non-rotation results in a narrow duodenocolic isthmus with a free hanging loop of midgut loop. This can lead to predispose to volvulus of the midgut. Because this loop hangs like this, this can rotate. Because there is no fixity anywhere, just only this particular loop is hanging from a small base. So that can rotate. And there may be associated band of Ladd, which can cause intestinal obstruction. There may be mobile cecum and ascending colon. This can predispose to valvulus of the cecum and colon. So I told you, in the third stage, ascending colon and descending colon, they will be fixed to the posterior abdominal wall. They become retroperitonealized. One of the errors is they fail to get retroperitonealized, they will be having mesentery. So when they have mesentery, they are mobile. So the mobile structures can undergo the rotation. That means torsion or volvulus. Now let's come to the topic, the volvulus neonatorum. The pre-response causes arrested rotation. The valvulus is in a clockwise direction. Clinical features: severe distension, vomiting, and rapid dehydration. Investigation: plain X-ray abdomen shows features of duodenal obstruction plus air fluid levels in the small intestine. Treatment: surgery. This is laparotomy. Reduction of valvulus by untwisting and division of any secondary obstructing lesion like transduodenal band of flat. So this is valvulus neonatorum. So the procedure is very simple. Just untwist it. The next condition is called meconium ileus. It is intestinal obstruction due to meconium. What is meconium? Yes, it is the first stool passed by the newborn. Yes, it is the first stool passed by the newborn. It is paste-like and it is dark brown or dark black in color. What is all this meconium due to? Why meconium the child passes? Where from it is developed? How meconium develops in the intestines? The child is not eating anything. How the meconium develops? Waste products. Where from waste products come? The intestinal epithelium is made of labile cells. Labile cells. I hope you know about the meaning of labile cells. What is labile cell? What do you understand by labile cell? No. It is not friable cells. Depending upon the regenerative potential, all the cells in the human body are classified into three groups. They are the labile cells, stable cells, and permanent cells. Labile cells, they have a great capacity for regeneration. Stable cells, they have moderate capacity for regeneration. Permanent cells, they do not regenerate at all. The example for labile cells are the mucous membranes everywhere. The mucous membranes of the alimentary tract, the mucous membrane of the respiratory tract, the mucous membrane of the urogenital system. So all of them, they are replaced once in every 3 days or 4 days. Some even faster. So for example, the mucous membrane of the tongue and oral mucosa, it is replaced once in every 2 or 3 days. That is why you get all that fur. So the intestinal mucosa is being replaced. That means every 2 days the old cells drop away, new cells they regenerate. So in the developmental process of a fetus, there will be a lot of new cells formation and there will be denudation of some of the cells and mucous membranes. All these denuded mucosal cells, they are made of protein. So all this gets digested by the pancreatic juices. We have seen pancreatic juices, they have the trypsin and lipase. So all these denuded mucosal cells, they are being digested by the pancreatic juices. And the bile coming from the liver, it stains all this digested material. and that stagnates in the intestines till the delivery of the child. So that is the meconium. So meconium is nothing but the digested denuded epithelial debris with the pancreatic enzymes and stained by the bile. So that is it develops that dark greenish or something looking like black color. So that is called the meconium. Actually, the literal meaning for meconium is the word is derived from Latin. In the Latin, meconium means poppy. Poppy. The poppy seeds. I hope all of you know about poppy seeds. From the poppy seeds only the opium is made. The opium, hypnotic, is extracted from the poppy seeds. So the old Greek literature, what they thought was God has given these poppy seeds to this child in the womb, so that it won't make noise. That's why the child was sleeping inside the womb. That is because of the poppy effect. So that is what the Greeks thought. That's why they thought that once the child is born, that poppy is excreted out, and child wakes up and cries. So that is how they interpreted. Of course, it is wrong. That is why they call that as meconium. Okay, this meconium causing ileus. Ileus means intestinal obstruction. So how this meconium, which is a normal production in the body, can cause ileus, let us see. Meconium is normally kept fluid by the action of pancreatic enzymes. The pancreatic enzymes are continuously being secreted by the pancreas. So their secretion will lead to digestion of this meconium, and it is kept in fluid state or semi-fluid state. In cystic fibrosis of the pancreas, there will be absence of exocrine secretion of the pancreas. The meconium in the terminal ileum becomes viscid, resulting in inspission in utero, causing neonatal obstruction. Of course, when we are talking about the disease of the pancreas, we concentrate upon only three diseases: acute pancreatitis, chronic pancreatitis, their sequelae, and carcinoma of the pancreas. So one of the other congenital abnormality of the pancreas is the cystic fibrosis. This is called congenital cystic fibrosis of the pancreas. It can be hereditary. In this, what happens? There will be multiple cysts with fibrosis of the pancreas. So because of this fibrosis and cyst formation, the acini are not developed. So this process of fibrosis of the pancreas and cyst formation of the pancreas takes place in utero itself. So as the child is developing, pancreas is not well developed, it is getting fibrosed and cystic. So there is small development resulting in absence of or decreased secretion of the pancreatic exocrine secretions. Because of these exocrine secretions are less, the meconium is not digested. That means the epithelial debris is being digested by only intestinal juices, but not by pancreatic juices. That means they are not efficiently digested. They are partly digested. So they become thick, paste-like, and very viscid. And that is called the meconium. So that thick paste-like, you can see here, this meconium, how much thicker and viscid it is. So it is very difficult for the fetal intestines to propagate them into the distal part. So they fail to propagate it, so they stay back there. So once they stay there, the water gets absorbed. So the meconium becomes thickened, and they become hard stones-like. So all this becomes thick, hard stones-like, and because they are viscid, they get stuck to the mucosa of the ileum. So mucosa of the ileum is stuck to this meconium, very much thickly adherent. So it blocks the intestines. So there will be intestinal obstruction in the fetus itself. Yes, of course, that is due to the mutation in the genes. Clinical features of meconium ileus. Family history may be present because this is runs in families due to the genes. There are features of acute intestinal obstruction in the newborn. When you open the abdominal cavity, you will see the bowels like this. There will be obstructed terminal ileum and cecum, and this contains a lot of stones. Like these stones are made of meconium. So hard stones of meconium will be blocking the ileum, and proximal to that one you will find a lot of mud-like material, and still proximal to that one you will see the great dilated ileal loops containing the tracheally fluids. So plain X-ray abdomen. So the feature of meconium ileus is only vomiting, abdominal distension, failure to pass the meconium. So the same thing will be there in the valvulus of the valvulus neonatorum, as well as it can be there in the jejunal atresia. Plain X-ray abdomen, distended small intestine will be seen with mottling. The fluid levels are generally not seen. The child will be passing only little amount of stool or vomitus. The child will be vomiting. So in that, the trypsin is absent. Because pancreatic cystic fibrosis is there, the trypsin is not secreted. So that is why the stools, if the child passes or if the child vomits, that vomitus doesn't contain trypsin. So there is a very simple way to investigate for presence of trypsin. What you do is, into a bowl of vomitus. So if the child vomits, so collect it in a bowl and place a small piece of exposed radiograph film. Probably must have seen X-ray films. X-ray films are coated with a thin film of some gelatin. Now, so take a small piece of exposed radiograph film, any radiograph film which is exposed. Place for an half an hour. Because that is coated with gelatin film, when you place in your vomitus, if the vomitus has trypsin, the trypsin will digest gelatin, and the X-ray film will become complete transparent film. Normally, when you hold the X-ray film and see, it is slightly opaque because it has a coating of gelatin. Once it is kept in vomitus containing trypsin, the gelatin gets digested. So once it gets digested, the film will be appearing transparent. But in case of meconium ileus, because there is no trypsin in the vomitus, when you keep a small piece of X-ray film in the bowl of vomitus, then that won't become that will be unchanged. So in the meconium ileus, the film is only becomes soft, but it will not lose the gelatin coat. And these patients, due to the genetic disorder, they have an associated problem with the skin. They will be secreting excess amount of saliva, excess amount of sweat. And the sweat contains a lot of more sodium also. So there is concentration of sodium chloride in sweat is greater than 80 millimoles per liter. And these children may have associated cystic fibrosis of the liver, cystic fibrosis of the lungs. So cystic fibrosis of the lungs can manifest as bronchiectasis in the newborn. So whenever you see such a patient with mottling on X-ray of the abdomen, absence of trypsin in the vomitus, then you can do a contrast X-ray. This is done with gastrographin. What is gastrographin? Gastrographin is an iodine-containing compound. Iodine is a radio-opaque material, just like barium sulfates. For example, if you paint iodine here on the skin and take the X-ray, you won't see the bones in my hand because iodine acts as a radio-opaque film here. So done with gastrographin. So this gastrographin is nothing but a iodine containing solution which is made in a palatable fashion. So when the patient swallows this, and this is also non-absorbed, this particular iodine containing compound is not absorbed from the gut. So when you give this gastrographin, this is not absorbed, this goes through the intestines and excreted from the intestines. Because it is water soluble, it can be aspirated. Sometimes it may even, this iodine containing compound may disperse the obstructing meconium. These meconium pellets or stones are adherent to the ileum. So when you give this gastrographin, sometimes by its dispersing action, it just acts like a soap. So because of its detergent action, it causes separation of these pellets from the intestinal mucous wall, and the pellets can be propelled forwards and obstruction may be relieved. Differential diagnosis: Hirschsprung's disease affecting the whole colon. Treatment: conservative management, gastrographin enema, IV fluids, surgery. If this enema, IV fluids won't work out, then you go for surgery. Do laparotomy. After laparotomy, you will find the thickened meconium pellets with dilated proximal intestines. So you have to relieve the obstruction. What the cause for obstruction? The meconium pellets. If you make an incision on the intestine and try to remove these meconium pellets, it is very, very impossible, because these meconium pellets were so strongly stuck to the ileal mucosa. If you try to remove them, you will peel out the intestines, peel out the intestinal mucosa also. That is why you don't attempt to remove those pellets. By enzymatic digestion, they must be separated and they must pass out later. So there are various procedures for this treatment. Sometimes this can lead to even gangrene of the bowel. You can see such a long segment of the bowel has become gangrenous. And what you do for this gangrenous bowel? You have to do resection. So when you remove such a large amount of bowel in a newborn child, so the prospects of survival are very, 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 very meager. This is another case of meconium ileus with dilated and gangrenous bowel. The procedures: resection and temporary stoma formation. That means the part of the bowel which bears these meconium pellets has to be resected. And then either you can do anastomosis or you can leave it as ileostomy. So you can do an anastomosis or you can leave it as ileostomy. Or you can do enterotomy, that means open the bowel and irrigate the bowel. Or you can do the Bishop-Koop operation. This is the Bishop-Koop operation. You can see here, terminal ileum is having these meconium pellets. The proximal part of the bowel is dilated and became atonic. So it is not having the peristaltic activity. So if possible, you resect this segment and do the end-to-end anastomosis. That is one procedure. Where you cannot do that, what you do is you cut the bowel and make it as ileostomy here. So normal ileostomy is done for the proximal segment, but here you are doing ileostomy for the distal segment. And the proximal segment is anastomosed to this distal loop. Now what you do after, then you close. So this is a very simple operation. What you do, the proximal part of the bowel is cut. The distal end of the cut segment is kept outside. The proximal segment is anastomosed to the distal segment. This is what you do. Postoperatively, what you do, now what happens? This acts as an ileostomy. So all these proximal contents, they will drain out. So once they get drained, the bowel gets its motility. That means it regains its tone after 3 or 4 days. This bubble, this part of the bubble, what you do is you pass a catheter and then daily irrigate it with hydrogen peroxide and some enzymatic solutions. So with that, all these pellets, they get digested and gradually they get loosened from the intestinal mucosa, and these pellets, they come out. So as they're coming out, ultimately all these pellets also, they come out, or they get loosened and goes through the intestines. So once the bowel gets cleared, then the discharge from this will be lessened, because the contents won't come like this now. Once the lumen becomes patent, all the intestinal contents, they go like this. Part of them come out like this. So when the discharge is becoming less and less and less means, so this is becoming more patent and patent. So then what you do is temporarily close it and check whether there is any distension or not, whether the child is passing stools or not normally. If the child is passing stools normally, then what you do is you permanently close it, push it inside, close the abdominal wall rent. So this is the Bishop-Koop operation. So resection of the most dilated segment with an end to side anastomos of the ileum to the ileum. The ileostomy becomes a mucous fistula, which is closed later. Necrotizing enterocolitis, this is also a surgical condition you see in the neonates. This is common in sick premature neonates. Here there is mucosal to transmural necrosis of the intestines. Clinical manifestations, features of enterocolitis, that means patient manifests with diarrhea and vomiting, and there is associated toxemia and lethargy. Plain X-ray abdomen shows pneumatosis intestinalis. Pneumatosis intestinalis. Pneumo means air. Pneumatosis, there is presence of air where in the intestinal wall. So this is called pneumatosis intestinalis. That means there is intramural gas. Normal gas is there in only the lumen, but in this condition, the gas bubbles are present in the wall of the bowel. Or sometimes there may be free intraperitoneal air. That means there will be necrosis of the bowel wall leading to perforation and leakage of air into the peritoneal cavity, producing the pneumoperitoneum. You can see here, in the center there is air, and in the periphery, if you closely watch, there are black dots. All these black dots are in the wall of the bowel. Treatment is excision of all necrotic bowel with primary anastomosis. So we have seen neonatal intestinal obstruction is caused by duodenal atresia. Intestinal atresia. It may be duodenal, jejunal, or ileal atresia. Then it can be due to meconium ileus, or it can be due to the volvulus neonatorum. So the newborn child will present to you first. So now approach. What is the approach for a child with bilious vomiting and abdominal distension? Clinical examination, including the examination of anus. Why anus? Sometimes there may be imperforate anus. Anus has not developed, there is no opening. So that may be cause for the obstruction. So that is very simple to diagnose. So first you examine the child and examine the anus. Take plain X-ray abdomen. Air fluid levels with supine film showing gas shadows means it is intestinal obstruction. So bilious vomiting patient, if you do X-ray abdomen, if you see air fluid levels, means it is a case of intestinal obstruction. If there is no air at all, It can be due to volvulus or the midgut. If there are calcifications, that means it is meconium peritonitis. If there is pneumoperitoneum, it is due to necrotizing enteritis. If it is pneumatosis intestinalis, again it is due to necrotizing enteritis. Then you give contrast enema with the gastrographin. I already told you it is iodine compound. By giving contrast enema, you find microcolon distally. That means the colon is collapsed. It is due to jejunal atresia or meconium ileus. Microcolon is absent. That means colon is normally dilated. Means Hirschsprung's disease. So that is how you will differentiate between the conditions here. I hope this neonatal intestinal obstruction is clear to you. If it is clear, then we will pass to the next topic, intestinal obstruction in infants and children. If you have no more doubts, we'll pass to the okay. In infants and children, the commonest cause being acute intussusception. Already I told you something about intussusception. It's nothing but telescoping of one part of the bowel into the other part of the bowel. This intussusception occurs when one portion of the gut becomes invaginated within an immediately adjacent segment, usually the proximal into the distal bowel. You can see here the ileum has advanced into the ileum. This is ileo-ileal intussusception. Here you can see the ileum has passed through the ileocecal valve into the colon. So this is a ileocolic intussusception. Etiology in infants and children, 70 to 95% the cause is not known. It is seen in infants of 3 to 9 months of age, probably due to hyperplasia of Peyer's patches, secondary to weaning or upper respiratory tract infection. So we have seen that intussusception occurs in some intestinal diseases. Can you tell me? In the previous topics, we have discussed about intussusception. So what are the causes for intussusception, what we have seen in the previous classes? Tuberculosis won't cause intussusception. How tuberculosis causes intussusception? Probably you may be thinking that the hypertrophic variety will produce a polyp, and the polyp will act as a drag point and it drags the intestines. No, it is not like that. Yes, very good. Meckel's diverticulum. Of course, polyps. These are the correct answers. Polyp usually is submucous lipoma. So hypertrophic patch of Meckel's diverticulum. So whenever some patch is there as a mass protruding into the lumen, that mass can act as a lead point and that will drag the intestines. So in the infants, the cause is not known. Probably it is due to hyperplasia of the Peyer's patches. The Peyer's patches become hypertrophic whenever there is some intestinal infection or even some general infection like cold and cough. So there will be lymphocyte hyperplasia. So whenever the lymphoid hyperplasia is there in the body, the Peyer's patches also gets hypertrophic. So these hypertrophic patches, when they protrude into the lumen, they can act as lead point for the intersusception to occur. Secondary interception, that is secondary to some polyp or some mass. This is seen in adults associated with the lead points due to Meckel's diverticulum, a polyp, submucosal lipoma, or a tumor. Peyer's patches hyperplasia. The hyperplasia of the Peyer's patches can be due to whenever there is some intestinal infection. So the intestinal infection can be due to when the child is breastfed and weaned, and child is habituated for the normal type of food. So there is some alteration in the food pattern. So that can lead to some amount of minimal subclinical infection. That infection can lead to hyperplasia of the Peyer's patches. So when they get hyperplastic, then they protrude into the lumen. So when they protrude into the lumen, one of these patches can act as a lead point and can drag the bowel during peristaltic wave. So here you can see what this is one of the examples of intersusception. So this is due to a submucosal lipoma. Already I have shown you this image. And interception has three parts: an entering or inner tube, that is called intussusceptum; returning or middle tube; a sheath or outer tube, that is called intersuscipiens; apex, that means the part which advances; the mass, that is formed by the intersusception. The neck is at the junction of the entering layer with the mass. The inner tube is prone for strangulation. Now you can see here, this is the bowel which has protruded into the colon. So this is the inner tube. This is the inner tube. And this is the returning tube. And that is the outer tube. This is the neck of the sac, so neck of the intersusception. So through this neck only, the vessels for this segment also will go. That means the mesentery also will go along with this here. That is why when the neck becomes very narrow, the bowels which are there inside, they get ischemic. Classification depending upon the segments of the bowel which got telescoped: ilio-ileal 5%, ileocolic 77%. That is the commonest variety. Ilio-ileocolic, that is 12%. Colocolic, multiple sites. Retrograde, sometimes the distal bowel goes into the proximal bowel. Colocolic variety is common in adults. Clinical features. So whenever there is intersusception, there will be pain. So the child will be crying with colicky pain. So sudden onset of screaming associated with the drawing up of the legs. So this is how you recognize a colicky pain in a child, because child cannot say how the pain is there. So the character of the pain they cannot explain. So there will be intermittent attacks of crying by the child. And during the act of crying, the child will draw both the lower limbs towards the abdomen and cry vigorously. The attack lasts for a few minutes, recur every 15 minutes, and becomes progressively severe. Later there will be vomiting and passage of red currant jelly stools. So this stools that is passed by the intersusception is described as the red currant jelly stools. There is nothing but a thick viscid mucus stained with blood. So because the inner tube, it becomes congested. The congested inner tube secretes a lot of thick mucus, and because of congestion there will be some amount of bleeding. So there will be blood staining with mucus. Unrelieved, this can lead to peritonitis due to gangrene. Because the mesentery is there on the medial side, it always causes a drag when it gets intercepted. So the mass will always be concave like this. It is not straight tube. It is always concave like this. So there will be a sausage-shaped lump in the abdomen with the concavity towards the umbilicus. On examination, a lump may be felt which hardens on palpation in 50 to 60% of the cases. There may be feeling of emptiness in the right leg fossa. This is called sign of D-dance. Distal rectal examination will show you blood-stained mucus, and occasionally in extensive ileocolic or colocolic interception, the apex may be palpable or even protrude from the anus. Investigations, plain X-ray abdomen, that will show you evidence of small or large bowel obstruction with an absent cecal gas shadow. Barium enema is diagnostic. It shows a sign called claw sign. Ultrasound scan shows coiled spring appearance. CT scan, equivocal cases may be evaluated by CT scan to reveal the presence of a small bowel mass. A laparotomy should be considered in equivocal cases. So where the investigations are not helpful, when the child is crying like that, so in any child aged between 3 to 6 years, if there is continuous colicky pain with blood-stained mucus, you must always suspect interception. So usually colicky pain with bloody mucus in the stools. What is your diagnosis? A child comes to you, is brought to you. Mother says that this child is weeping crying from the past 6 or 7 hours, and there is a lot of mucus with blood staining repeatedly. So what will be your diagnosis? What will be your first diagnosis? I am talking about a general child. Don't think about interception. I am not talking anything about interception. I am just telling you are a doctor. I don't say you are a surgeon. You are a doctor. A child is brought to you. Mother says that child is crying for the past 6 hours. And child is passing about 10 to 15 times mucus with blood in the stools. So what is your diagnosis now? Tell me. You examine the patient. Yes, it is the common cause, that is a dysentery. So usually we consider this as a case of dysentery. So most of the interceptions are diagnosed as dysentery. So if any child is brought to you with history of dysentery, you must always do distal rectal examination of the child. If it is a very advanced interception, you will be able to feel the interception by distal rectal examination. And when you do abdominal examination, when the child is quiescent, that means pain is not continuously, it is intermittently. The child cries for 2 minutes, then stops for 5 minutes, again cries for 2 minutes, again stops for 5 minutes. So in this intermission, where there is no crying, then you palpate the abdomen gently. Then you will be able to feel the mass in the case of interception. So whenever a child is brought, don't be under the impression that, oh, it is a simple case of dysentery, and so don't give medicines. You must always, always, and always exclude interception. When doubt is there, send him for ultrasound scanning. You will see a coiled spring mass inside the abdominal cavity. Or else you can go for CT scan. I will show you the CT scan findings also. So still if you have a doubt, then you go for laparotomy. Otherwise, a large bit of intestine will become gangrenous if you wait for more than 7 to 8 or 9 hours. So by the plain X-ray, what you can say? You can't say anything. It is just a case of air shadows in the ileum. This is the barium enema. This is very useful. You can see this is called the claw sign. So because the interception is coming here. So here is the inner tube. So this is the space between the inner tube and outer tube. So into this space the barium enters. So you can see the barium entering. So this way, because of this projection, they appear like the claws. So in one of my patient, you can see barium enema is given. The barium has gone up to here, and now you can see the claw sign here. This is the interception coming into up to the hepatic flexure. So you can see the interception here. Ultrasound scan, you can see something like a coiled spring appearance. So this is very typical of interception. Similarly, a similar sign will be there on CT scan. So there will be 3-layered intestinal wall. So of course the edematous inner tube, the edematous outer tube. So you can see these two tubes here, one tube inside another tube. So this is called the target sign. So there is a doubt from one of our students, how will the enema go through the inner tube? So to clarify that doubt, I will just go behind. This is the inner tube. The inner tube is not filled. It is black. That means it is not filled. The white filled is the barium. So the barium is filling outside the inner tube. So this is the inner tube which is not filled, and this is the barium which is filling the outside. That means the space between the inner tube and outer tube. So that space is being filled by the barium. That gives the appearance of the claws. So not that the barium goes into the inner tube. Inner tube can't be filled. I hope it is clear. Santi, is it clear? You can see here the barium won't go into the inner tube. No, it is barium enema. That means you are giving barium through the anus. You connect the enema tube and then give barium sulfate through the rectum. So the rectum is filled, descending colon is filled, and then it fills to the distal side of the interception. So inner tube is already inside, outer tube is nothing but the colon. Into the colon you have given barium, that gets filled. Because inner tube is here, it is not getting filled. I hope it is clear now. So this is the target sign. And barium meal don't give in a case of intestinal obstruction. Already I told this point in the previous 2 or 3 classes. Now also I am repeating. Whenever you want to do a contrast enema in the suspected case of intestinal obstruction, it should always be a water-soluble contrast X-ray, either barium as a meal or as enema. But barium never as a meal. Barium can be given as enema in case of obstruction without gangrene or perforation. If there is no suspicion of gangrene, if there is no suspicion of perforation, we can give barium enema. So differential diagnosis of intussusception, enterocolitis. There will be patient will be having abdominal pain and vomiting are common with occasional blood and mucus in the stools. Diarrhea is a leading symptom, and fecal matter or bile is always present in the stool. So this point is very important. In enterocolitis, though the patient passes a lot of mucus with blood, there will be also some amount of fecal matter. If there is no fecal matter, only child is passing blood and mucus, blood and mucus, blood and mucus, means it can be intussusception. Then purpura, it may be associated with characteristic rash and child will be crying with pain. Of course, purpura may also be associated with intussusception. Sometimes intussusception may protrude from the anus. Then you are differentiated from rectal prolapse. If it is intussusception, you will see a tube coming out. That means you can pass your finger by the side of the tube inside the rectum from the anal canal into the rectum. If it is a partial prolapse or prolapse of the rectum, so you can't insert your finger by the side of the mass. Treatment, conservative treatment, hydrostatic reduction with water enema or barium enema. Now I will draw here. This is the colon. Now into the colon, the small bowel has been telescoped. So this is the inner tube and this is the outer tube. When you give barium enema, the enema goes like this. The inner tube is got compressed because it's a very small tube, a tube inside a tube. So the inner tube is subjected to pressure from outside. So it is always compressed. So its lumen is blocked. So the inner tube is always blocked. That's why if you give barium enema, the enema don't go into the inner tube. That is number one. Number two, if you give enema like this and increase the pressure, that means how you give enema? Enema can will be there. The can will be having a tube. The tube is connected to the tube is passed into the rectum, and you hold the can at a 3 feet height or 1 meter height. So at 1 meter gradient, all the barium sulfate suspension will go into the rectum. That is normally what you do. But in case when you see intussusception, then as a treatment, what you do is you connect the barium, pass the tube into the rectum, and hold the two buttocks tightly against the tube. That means to close the space around the anus. Then lift the enema can to a 2 meters height, not 1 meter height, it's 2 meter height. So when it's lifted to 2 meter height, what will happen? The pressure inside the So the gradient will increase. So automatically the pressure inside the colon will increase. So this barium may push this bile outside. Gradually it may push it out. So once it got reduced, then patient will be passing flatus, feces, and patient gets relieved from distension and pain. So this is called the hydrostatic reduction. You can give simple plain water also as enema and try this. You do it for 3 or 4 times. You put it in a plain water in little warm water in a can, pass it like enema, and hold the can at 2 meters or 2 meters height, then afterwards at 3 meters height. Then what happens? All the fluid will go into the colon at a high pressure, and this high pressure will cause pushing effect over the interception, and interception will gradually get reduced. Yes, in inception, clinically, first what will happen is the patient passes feces first 1 time or 2 times. Later on, the patient will be passing only mucus with blood. But in enterocolitis, always there will be feces along with mucus and blood. So it's not only mucus. It will be some blood, mucus plus fecal matter. Little fecal matter which is thin and flocculent, watery. Watery fecal matter will be there in case of dysentery. Without any fecal matter, if patient is passing, child is passing, only mucus means you must always suspect the interception. So this is called hydrostatic reduction with water enema or barium enema. Repeated enemas are given with saline till the flatus and feces is passed with force. So if the patient passes feces means interception has been reduced. Contraindications in the presence of complete obstruction. Peritonism, whenever there is some guarding, you should not do this enema experiment. If there is prolonged stay of more than 48 hours, you should not do this because there is suspicion of gangrene if it is more than 48 hours. Surgery, failed or contraindicated conservative management. Reduction is achieved by squeezing the most distal part of the mass in a cephalad direction. That means once you open the abdomen, you will feel a sausage-shaped mass, bowel entering into the bowel. Then you should not try to hold this proximal part of the bowel and try to pull it out. You should not do pulling. You must always push it from cephalad direction. That means you place your fingers at the apex of the interception and try to knead it down. Try to knead it down. The bowel should not be pulled. Please remember that. The viability of the bowel should be checked after reduction. Sometimes the inner tube will be gangrenous. Then you have to resect it. The underlying cause requires appropriate treatment. If there is a submucous lipoma or anything like that, that should be removed. In the presence of an irreducible or gangrenous interception, the mass is excised and anastomosis. Of course, this is a small video clipping to just tell you that you should always push from apex side. You should not pull from the proximal segment. So this is only to show you 2 elephants, a mother and child elephant, how the mother elephant saves the child elephant. A small video clip to highlight the you can see here a baby elephant dropped into skid into a canal. She is trying hard to come out. It is unable to come. It is trying all its efforts to come out. So it is crying for help. So now the mother elephant is coming to her rescue. So like the principle in the interception, the mother elephant is not trying to pull it. It wants to push it. You can see how it pushes it. You see, that is how you should reduce the interception. I hope you understood the philosophy of don't pull, only push. So this is again another example of interception. This is one of my cases. You can see here, interception. This is just like a sausage shaped mass. It is curved, concave towards middle side. So this is the inner tube which is going. The mass is being kneaded out. So you have to knead it down like this. So when you pull it up, push it out, you can see this part has become gangrenous. So the inner tube is gangrenous. That's why you have to resect it and do the end-to-end anastomosis. So always check for darkness. So when it is frankly dark like this, it is gangrene. Sometimes it is of doubtful viability. That means it is not the normal pink color, but it is very much dark. Then you get a doubt. Then what you do? You take a mop, soak it in hot saline, and wrap the intestine with that hot mop for 10 minutes. Request the anesthetist to give 100% oxygen. After 10 minutes, you take away the mop and look at the intestine. If the color changes to light purple color, with return of pulsations in the mesentery, with return of peristaltic activity of the bowel, that means it is viable bowel. Otherwise, you have to resect it. Once you reduce the interception, the child will never get the interception again. But sometimes you will find recurrent interception. This is rare. Then what you do is you anchor the last part of the terminal ileum to ascending colon. So take the ileal loop, keep it. For example, this is the ascending colon. This is the ileum. Or you will see this wire. You just attach it like this to the ascending colon. The next cause of obstruction in the children is due to ascariasis. Ascariasis is caused by infestation due to Ascariasis lumbricoides. This may cause ileal obstruction, particularly in children. Sometimes it can cause cholestatic jaundice or even acute pancreatitis. Life cycle, of course, you read it in your pathology, sorry, in your parasitology. Contaminated food ingestion brings eggs into the gut. Larvae are released and travel to the liver via portal circulation. Larva passes through the liver into the systemic circulation and reach lungs. Larvae mature and reach the alveoli and can produce the Loeffler syndrome. They are coughed out or ingested into the intestinal tract again. In the bowels, maturation continues to develop in the adult parasite inhabited in the small bowel. In the small bowel, it causes malabsorption, anemia, colic, etc. And when a bolus of worms enter the ileum, acute ileal obstruction develops. So sometimes what happens is, in any child, if any child is brought with repeated acts of colicky pain, we always suspect it is due to some parasitic infestation, and we give some albendazole tablets or syrup to this child. That is when 1, 2 or 3 or 4 worms are there here and there in the intestine. But sometimes what will happen, a bunch of worms will be there in one part of the ileum, causing the blockage. You can see here, sometimes a bunch of worms, they will be clogging the intestines. So a bolus of worms in the bowel, usually the ileum, causes partial or complete intestinal obstruction. The worms can also cause perforation of the bowel. Types of obstruction, it can be usually subacute, sometimes it is acute. Subacute obstruction, yes, the worms will pass in feces also. The recurrent attacks of colic, vomiting, mild fever, with or without constipation or diarrhea. Mild to moderate abdominal distension. When you give, if there is no obstruction, of course you can give barium. When you give barium, you can see the worm like this. But whenever doubtful about obstruction, don't give barium. Acute obstruction frequently follows antihelminthic therapy. Now, when the child passes worms in the stools, they can be live worms also. The worms will be moving also. Sometimes the parents will bring the live worms in a small box, showing that this worm is passed, and the worm will be moving. I have seen many a times a live worm which the parents has brought, that was passed by their child's feces. So acute obstruction frequently follows antihelminthic therapy. Child is already debilitated because of parasitic infestation. So whenever you see a child in a debilitating condition with obstruction, think of the ascarial obstruction. There will be eosinophilia. If perforation has occurred, sometimes it can cause perforation also. There will be fits of peritonitis. Investigations, plain X-ray abdomen, evidence of obstruction, features of perforation if present. Treatment, conservative treatment plus antihelminthics will be usually sufficient to relieve. That means you give oral albendazole, mebendazole, or ivermectin. Usually these are given after the acute colic has passed away. If given during colic, the paralyzed worms may get bundled again and precipitate the acute obstruction. If no relief, surgery. The operative treatment, to knead the tangled mass into the cecum. So what you must do is, don't open the ileum. So try to knead all these tangled mass into individual worms and then push them into the cecum. So that is of course a messy job. If it is not possible, open the bowel and remove the mass of worms. Then closure of the bowel wall is done with non-absorbable sutures, because roundworms are known to migrate through suture line. If perforation is there, Resection of the disease segment plus removal of the worms from peritoneal cavity and peritoneal toilet is done. Sometimes there may be perforation and the live worms will be there moving in the peritoneal cavity. So remove all those live worms, resect the segment which is diseased, and do end-to-end anastomosis. In a patient who is debilitated, he cannot withstand all this procedure. In that case, what you do is you bring out the perforated bowel as ileostomy. So once ileostomy is done, all the fecal matter can drain outside. So once obstruction is relieved, the child's condition improves. So once the improvement is there, then you can do reopening and do the anastomosis. Sometimes the patients will be very toxic. In case of ascaral obstruction, they will be running high fever, they have vomitings, dehydration, sepsemia, and obstruction with perforation and peritonitis. So these conditions, they have certain mortality also. So mortality is around 10% and occurs usually in cases presenting late. Yes, the worms, if they die, means they liberate a lot of toxins. That's why they produce this toxic material into the gut and they get absorbed and that produces the problem. Differential diagnosis of vomiting in infants and children. Bile-stained vomiting. Neonates, malnutrition of the gut with volvulus, duodenal atresia, anrectal malformation, spectral disease, meconium ileus, and necrotizing enterocolitis, obstructed inguinal or umbilical hernia. In older infant, this malnutrition with volvulus, intussusception, obstructed hernia. Non-bilious vomiting, congenital hypertrophic pylori stenosis, gastroesophageal reflux, feeding problems, systemic diseases like infections, metabolic disorders, and congenital adrenal hyperplasia can cause the non-bilious vomiting. Then internal obstruction in adults, adhesions and bands. This is the commonest cause of intestinal obstruction. Causes of adhesions. Adhesion means the bowel gets stuck to abdominal wall. That is called, it gets adhered, or bowel loops gets adhered to one another through a medium of fibrous tissue. And this fibrous tissue which is adhering these bowel loops are called adhesions. If the adhesion, if a wide fibrous structure is there, we call it adhesion. If this adhesive structure is like a band, we call it as bands. So these adhesions and bands are same. If it is narrow, string-like, we call it as band. If it is flat, wide, we call it as adhesion. The causes being post-inflammatory, following peritonitis, following tuberculosis, Crohn's disease. Post-operative, this is a very common cause. Why following operation there will be adhesions? Because of introduction of foreign material. What is foreign material? The unabsorbable glove powder. Say glove powder, that means the surgeons don gloves. For easy penetration of fingers into the gloves will be powdered. They will be powdered with talc or starch. So this will be this will be like dust over the surface of the gloves. When you open the abdomen and then you explore, you touch the bowels, all this dust will be falling into the peritoneal cavity, and that acts as a foreign body, and that foreign body will cause adhesions. That means the foreign body will produce foreign body granulomas. Granuloma is nothing but fibrous structure. So there will be fibrosis. And also this foreign material can be due to silk sutures or sometimes due to gauze. The post-operative adhesions usually involve the lower small bowel. Operations for appendicitis and gynecological operations like hysterectomy are the most common conditions and are indication for an early intervention. Then post-radiation additions, then following drugs like pranolol, which is used as an antihypertensive. Pathology, any peritoneal infiltration due to foreign body, due to inflammation, causes local fibrin production, and this leads to adhesions between the opposite surfaces. Early fibrous adhesions may disappear when the cause is removed. They may become vascularized and replaced by mature fibrous tissue. Classification according to time of onset. Early fibrinous occur during 1st to 5th days. Majority are treated by conservative measures. Late are called fibrous. That means the fibrous bands or adhesions have organized themselves into fibrous tissue. That means this is collagen. This is fibrin. These occur after 7 days. Surgery may be needed for these fibrous adhesions. For fibrous adhesions, they can be managed by conservative management. They occur usually during 1st to 5th day after surgery. Now you can see here, this is the abdominal wall. This is a loop of bowel. Now it got adhered to the abdominal wall at the previous stage of surgery. You can see here, there is one loop of bowel. Here is another loop of bowel. Both of them got adhered by these adhesions. When you cut this adhesion, if it is a long band is there, a long adhesion is there, you can cut in the middle. Sometimes they will be very short. Bowels are adhered to one another like this. So when they are stuck to one another, when you cut in between, you will have the raw areas like this. This is non-peritonealized surface. The peritoneum also got denuded here. Peritoneum and some amount of muscle tissue of the bowel has been lost here. So in the process of adhesiolysis, you should not leave this raw area like that inside the abdominal cavity, because when there is loss of muscle coat here during peristaltic activity, this becomes weak. So sometimes it may cause perforation. That is why you must close it. So whenever you want to close this one, you should not close it longitudinally. If you close it longitudinally, it produces stricture. So what you must do, you put a hook here, another hook here, and pull it like this. So a horizontal thing will become vertical. Then you can do the suturing. So you can see here, the horizontal structure is sutured vertically. Prevention of adhesions. The following factors may limit adhesion formation. Good surgical technique. You should not be rough towards the intestines. You should be gentle. Washing of peritoneal cavity with saline to remove clots, gauze, glove powder, etc. at the end of the operation. To cover anastomosis and raw peritoneal surfaces. Usage of soluble glove powder that is called potassium bitartrate. So instead of starch or talc, it is always preferable to go for the soluble glove powder. Bands. They can be congenital, like obliterated white yellow intestinal duct. Already we have discussed the anomalies regarding white yellow intestinal duct. It can be like a band. Can you tell me the other anomalies of white yellow intestinal duct? What are the other anomalies of white yellow intestinal duct? Normally it gets obliterated. Sometimes it fails to obliterate. So it can form, as you said, Meckel's diverticulum, very good. As someone is telling, it is berry. What berry? You're right. Something before berry is there. There is a prefix for this berry. What is it? Okay, that is raspberry tumor. Raspberry tumor of the umbilicus. Okay, one is Meckel's diverticulum, the second is raspberry tumor, the third one is third anomaly, a cyst. Fourth anomaly, total patent vital intestinal duct with fecal fistula. Yes, fecal fistula. Then fifth anomaly, a band. Totally got obliterated, becomes a band, not disappeared. So this is the band. So the vital intestinal duct, if it is obliterated but not disappeared, it forms a band like this. The additions over a period of time gets converted to bands. So this is addition, it gradually converted to band like this. Clinical presentation, subacute or acute intestinal obstruction due to kinking, torsion, or entrapment. So the bowel is adhered like this, it will produce a kinking. If for one loop of the bowel there is a band attachment, then basing this as a pivot, the bowel loops can rotate and can produce torsion. If the band is adherent to the abdominal wall, between the abdominal wall and the band, a bowel loop may get entrapped. Treatment, initial management, conservative. We should not prolong more than 72 hours. Surgery, the responsible band or addition is lysed and the remaining are left in situ unless severe angulation of the intestine is present. So when you open the abdomen for managing obstruction due to bands or additions, so one band is responsible for obstruction. You remove that band. How do you say that particular band is responsible for obstruction? There is distal collapsed bowel, proximal dilated bowel. At the junction of dilated and collapsed bowel, there is a band. There is an addition. That is the responsible one. So you lyse that one. Afterwards, you explore. You will find multiple bands and additions here and there. So wherever you can cut them. But don't try to remove all the bands and additions. There is no need. There is no use. Once you cut a band or addition, again a band will be forming there. So which causes severe angulation of the intestines only has to be lysed. Otherwise, division of all these additions will lead to further addition formation. The bare area in the intestine should be covered with omental grafts or by Lambert suture. So this is the bare area left after adductolysis. So you must always close them perpendicular to the axis of the bowel. So like this, they must be sutured. Sometimes the patients may come recurrently with intestinal obstruction due to additions. You remove additions, obstruction is relieved. Again, 1 year later, the patient will come to you again with additive obstruction. So what you do, repeat adductolysis. You can do Noble's plication, Charles Phillips transmesenteric plication, intestinal intubation. These three things were the old operations that is not being performed now. This is Noble's plication, where you keep the bowels like this, like step ladder, and suture them, so that even if they get adhered, there will not be obstruction. But it's very difficult to do like this. Some people keep the bowel loops like this, and they put long synthetic suture materials through the mesentery to keep them in this position. And subsurgeons just do what they do is they put a long tube through the bowels and keep it like that, because tube is a stiff structure. So if you leave it like that for about 3 or 4 weeks in the intestines like that, the intestines, because they have tendency for adhesions, they will adhere in this fashion. Because when the tube is there, because the stiffness of the tube, they don't get angulated. So when they get adhered, they will be adhered without any angulation. So if there is no angulation, there is no question of obstruction. So this is about the intestinal obstruction in adults. We have still 2 more topics are left behind. So we will study those topics along with intestinal obstruction in the elderly in the next class, that is tomorrow. So I will stop the class now. If you have any doubts, I will clear them. Otherwise, I will exit the show. Any doubts? Okay, if you have no more doubts, I will close the session. Thank you very much. See you tomorrow at 4 p.m.